Thank you. I want to start off our evening by first thanking our contributors for all that they've done in making this event possible, particularly Walgreens this evening. I'm really excited about this evening's discussion on community resilience. So y'all think it's hard to do health disparities. But think about health disparities in a hurricane, health disparities in the middle of a natural disaster. Our job is to make sure that we're delivering quality care no matter what the environment is. You know, as the postman says, neither rain, sleet, or snow will keep us from our appointed route. And our route is to provide quality care to all Americans all the time, particularly when the system is under stress by natural disaster. So we've put together really an excellent panel for you this evening. For those of you who have not been thinking about community resilience, to get introduced to the topic, I think you're in for a treat. Thank you. I'll now turn it over to the panel.
Thank you, Dr. Puckrein. So in preparation for this panel, and good evening, and thank you all for being here. I'm Dr. Loren Robinson. I'm the Deputy Secretary for Health for the Commonwealth of Pennsylvania. And we've assembled a team of what I would call experts here tonight to kind of lead us through concepts of resilience. When I was preparing for this panel, I wanted to start with a definition. In public health, definitions are very important. And so Merriam-Webster describes resilience as the ability to recover quickly from a challenge or from a difficulty. I thought to myself, there's got to be more to it than that. We like very robust definitions in public health, and so I will read you all a public health definition of resilience, and then we'll jump right in. So resilience is defined as the ability of a community to use its assets to strengthen public health and healthcare systems and to improve the community's physical, behavioral, and social health to withstand, adapt to, and recover from adversity. And I felt like that was a very robust definition, and one that allowed us to make spaces for whoever needs to speak from their experience, but more specifically to allow the experts to weigh in on how their specific industry or sector has either responded to or faced and a challenge, and what resilience meant to them. This evening I've asked Representative the Honorable Stacey Plaskett to kick it off for us. She is the U.S. representative from the U.S. Virgin Islands at large. And I've asked each individual here to speak for about 5 to 7 minutes about their experience with resilience. Then I will ask some questions, and I think most importantly, there will be plenty of time for the audience to ask questions this evening about how we as different communities and as one community can respond to resilience.
So thank you very much for that introduction. I want to thank you all for being here this evening. Of course, thanking National Minority Equality Forum for putting this together, as well as the Congressional Black Caucus Braintrust for their work in this area. I want to acknowledge my predecessor, who's here as well, and has really been at the forefront of healthcare issues, not just in the Virgin Islands, but throughout the country. The Honorable Donna Christensen, who is here and really continues to do the work. And so with that, I wanted to talk about what does resilience mean in the Virgin Islands. You'll see the slides that are going to be moving while I'm talking are really talking about what happened in the immediate aftermath of the hurricane. You'll see what physically the island looked like. And I think it's important to understand that for the U.S. Virgin Islands, as well as so many other islands, and particularly Puerto Rico as well, what the hurricanes did was take off the veneer, as well as rip the Band-Aid that local government and local nonprofits and others were doing to hold things together, and really shined a light on so many of the fundamental issues that were already at play in the U.S. territories. When you talk about issues of health, issues of education, infrastructure issues, all were, the storm really exacerbated already pre-existing conditions that were on the ground when you talk about health. The Virgin Islands, of course, you all may very well be aware that Congress has really done a job not only in the U.S. Virgin Islands, but as well in Puerto Rico, in terms of how funding is done for us in the healthcare area. So we have an arbitrarily low that is not based in any prescribed formula cap on the funding that we receive for Medicaid and Medicare. We also are not participants in the DSH program, the disproportionate share for hospitals, which if you look at our population and its demographics, would seem that we're just a poster child for such a program. Additionally, in the areas of infrastructure, when you look at the infrastructure that we have, we in the 1990s were removed from the usual formulas for that transportation and infrastructure had for roads, for ports, etc., put it arbitrary differences, and even just regular funding. Virgin Islanders have an income rate and a poverty rate that puts us in line with the same as Mississippi. And Mississippi receives about 44 cents to every dollar of their general fund comes from federal funding, whereas the Virgin Islands and Puerto Rico receive about 14 cents per the dollar. So that really was a stretch on our general fund, as well as on the resources of the island before the storm. You all have talked so well in years past about disparities, the fact that we are really a hotspot for issues such as diabetes, hypertension, and all of the diseases that are surrounding that, and the storm exacerbated that. So when you look at the hospitals had really not spent a lot of their funding on dealing with infrastructure issue. A lot of the deferred maintenance for roofs and infrastructure were not used in those areas, but were really spent on spending money to the healthcare providers, on having patients that are not non-paying patients. About a third of the people in the Virgin Islands do not have health care. And when I say do not have health care, do not have Medicaid, do not have Medicare, do not have private insurance. And so these are non-paying patients that were going to our hospitals, going to our clinics, et cetera, before the storm. And so a lot of the structure that should have been spent on roofs, on maintenance, did not get met. And so you find that on St. Croix as well as St. Thomas. So remember, we have to duplicate services because of the distance between us. There were breaches in the roofs, areas that were completely blown out in certain parts of the hospital, the clinic on St. John as well. You look at our school structure. We've lost more than a third of our schools in the Virgin Islands. Our children are on shifts in school right now, so all of the young people have 4-hour shifts in which they participate in school because they have to share facilities with other people. About 2 months ago, I walked into a principal at one of the high schools to find out how she's doing, to go and talk to the students to see what's happening. She told me that 23% of her seniors were failing. And a lot of that is not just because they're in 4-hour shifts, but 19,000 homes were damaged in the Virgin Islands. So students may be living with relatives. They may have relatives living with them if their home is intact, or they may be living elsewhere. We lost a lot of our students. And so the area that I think it's more interesting for you all and something that you can wrap yourselves around is that because of the infrastructure damages that we had in our healthcare system, so many of our inpatients, as well as our chronic care patients, dialysis patients, et cetera, had to leave and are still not on the island. And it's believed that we have at least 200 losses of life after the storm for those that are receiving care off island, that are not with caregivers, not with family, friends, and others, but are in areas like Atlanta, Florida, et cetera, where they are receiving excellent care, but they're not getting the nourishment and the sustainability of their own community. So our issues now and our challenges in the Virgin Islands are, yes, Congress has allocated substantial funding to the rebuilding, and that's really a foundation for us with which to begin thinking about what the Virgin Islands need. But the question on the ground that needs to be asked is, How are we going to build to sustain ourselves in the long term? How are we going to address not only the lack of funding that we receive, but also issues like electricity? Here in the DC area, you pay about 10 cents per kilowatt hour. In the Virgin Islands, a good amount would be 33 cents, 36 cents, 40 cents. We have antiquated generator systems that we're still paying for, along with the need for fossil fuel and redundancy in systems, as well as the fact that 90% of our utility system was destroyed by the storm. So our rebuilding has to be very smart, has to be very strategic about meeting the needs that are immediate for the people of the Virgin Islands, but also address long-term needs.
Thank you very much, Representative Plaskett. Our next presenter will be Dr. Joshua Sharfstein, who is the Vice Dean for Public Health Practice and Community Engagement at the Johns Hopkins Bloomberg School of Public Health.
Great. Thank you. And it's just remarkable what is happening in the Virgin Islands and your leadership. It was really tremendous. I want to go back a little bit more than a decade for a different kind of disaster in the man-made category. I don't want to say Congress-made, but maybe. It's the implementation, the implementation of Medicare Part D, if you remember, which is the pharmacy benefit. And I was working for a member of Congress, and I told him I was applying for a job that I didn't want and I wouldn't get, and I wasn't qualified for, which was to be the health commissioner of Baltimore City. And I wound up getting that job, and I started 2 weeks before the implementation of Medicare Part D, and the discussion on Capitol Hill was how that was going to be a difficult transition because all of these patients were switching from a benefit, if they were dual eligible, that was pretty simple. They could go to whatever pharmacy and get whatever medicine, to a Part D plan, which would have a restricted formulary potentially and restricted set of pharmacies. And I jumped in right away with the congressman that I had worked with quite a lot in Washington, Congressman Elijah Cummings, and we went to different senior centers telling people, be careful, make sure you sign up, we don't want you to lose your coverage, particularly for 28,000 dual eligibles who were incredibly vulnerable, people who had seizure disorders, psychiatric disorders, everything. And you know, it was complicated. I mean, like, it's hard for us to understand. And here people had to, you know, fill out all these forms, figure out what plans to do. And Congressman Cummings turned to me and he said, this isn't going to go well. What are you going to do about it? And I was like, well, I mean, isn't that CMS's responsibility? And he looked at me and he said, I thought you wanted to do this job here in Baltimore. You know, I recommended you to the mayor. So I went back to the health department on literally my first day, and I said, we're about to get hit with something. People don't realize it, but there's a big challenge with implementation of Medicare Part D. What can we do? And we started brainstorming all these different ideas. We talked to people who work with seniors. We got their ideas. Finally, you know, we were going to try to reach everyone, knock on everyone's door. That seemed like a hard thing to do with 2 weeks of time to go. And then someone said, how many pharmacies are there in the city of Baltimore? And the answer to that question was 125. And we said we could visit all 125, and we could tell them if someone shows up and can't get their medicine, the city will pay. And we will then try to track it down. We don't want the patient to bear the brunt of the confusion. And I went to the mayor, Mayor O'Malley. He gave us $100,000. We used this technology some of you may have heard of called a fax machine. And we faxed every single pharmacy. I'm a physician. I got to do the really exciting thing of going behind the counter at a pharmacy, which was like this incredible rush. And I got to see what it was like. And they showed me that there were these phone numbers you could call for Medicare Part D help. And we wound up not only giving out maybe for 100 people who couldn't get their medicines, but we were also every day faxing updates. This number works. This number might have 8 hours of hold time. This number works. And we did regular reports, and I noticed that the CMS director had signed up his email for our regular reports from Baltimore. And working with all the different senior organizations, community organizations, and the pharmacies really as major allies, we were able to weather that storm. And the lessons I took for that is, number one, it is your problem. It is not someone else's problem. If you see something coming, you've got to figure out what you can do and what your organization can do to be a part of the solution. Number two, you have to think about all the assets in a community. I thought that was a great part of your definition. And for us, I had really never really thought that much about pharmacies as more than just places you go to get stuff, as opposed to places that are really critical. And subsequently, I've done many different kinds of public health interventions with pharmacies. And finally, that sometimes you have to be creative and think a little bit differently about what might be possible. And resilience is sort of an interaction between people who see the challenge coming, people who are there and know what it'll take to be successful, people who have direct relationships with the people most at risk, and the different resources that exist in a community.
Thank you, Dr. Sharfstein. Next, we'll have Amanda Quinton, who is the Senior Director for Workplace Solutions from Walgreens.
Thank you. I really appreciate the opportunity to be here on behalf of Walgreens and to talk with all of you about our retail pharmacies and how we continue to support our communities as we see disasters hit. So my role at Walgreens for the last 13 years has really been to ensure the resiliency of our company so that ultimately we can ensure the resiliency of our communities and the people that are in our communities. And really the point that I'd like to make today is that retail pharmacies like Walgreens really can play a critical role in that community resiliency plan. We do this in the best of times by providing pharmacy, health, and well-being services in thousands of locations nationwide, especially in overlooked and underserved communities such as medical deserts that exist, where there's few convenient health services that are out there and available for people. But we're also out there in the worst of times when we're needed the most. Like last fall, when Hurricanes Harvey, Irma, and Maria back-to-back tore through devastated communities across the South, Puerto Rico, and the Caribbean. We embrace our special responsibility to keep on providing medicine, food, water, and essentials when disaster strikes. And that means we need to be stronger than the storms and the disasters that hit us. This is both a corporate commitment and it's a personal commitment that I have to the company, as well as to our patients. We live in the communities that we serve, and our customers and our patients, they're our family, they're our friends, they're our neighbors, and so it should be personal to us. So our concern really is twofold. We need to protect our team members and our families, but we also need to stay up and running and be able to provide medicine and the care to our patients that really need us within our communities. When disaster's coming, we're prepared. In our Emergency Operations Center, it includes field leaders, distribution center leaders, asset protection team members, community affairs, enterprise security, pharmacy operations, and the list just goes on and on. We have people and systems that are in place to prepare and monitor the situation on the ground in real time, and people that can leap into action at a moment's notice. The amount of assets, planning, and effort that we invest in our disaster recovery program might surprise some people who think that we're just a corner drugstore. Let me give you a few examples of how our teams were able to really step up and help people that were in dire straits. In Texas, after Harvey, we donated food items, first aid, and medical equipment, including blood pressure cuffs, catheters, and transport wheelchairs. We donated this to the American Red Cross Emergency Shelter that was at the Houston Convention Center. We worked with United Airlines in order to transport critical first aid and medical items from Chicago down to Houston on a flight with relief supplies. And one of our waste haulers, one of our vendors, they rescued people that were trapped in floodwaters and brought them to safety. One of our pharmacy managers at the Women's Hospital of Texas in Houston took it upon herself to compound medications for mothers and babies that were in the intensive care unit. And in Florida, after Irma, we provided gasoline to local law enforcement agencies to address their shortages. We reopened nearly all of our stores within 3 to 5 days after the hurricane made landfall. We also relocated specialty medications which are needed by patients with acute and chronic conditions to protect the integrity of those medications so that we could redistribute them as soon as we were able to. In Puerto Rico, we partnered with the American Diabetes Association and our pharmacy suppliers to provide critically needed insulin and also vaccines against contaminated food and water. We sent temporary pharmacies to locations in dire need of medicines, and some of our team members actually delivered critical medications via helicopter to rural areas that couldn't be reached via normal vehicle. Our pharmacists visited shelters. We delivered immunizations and prescriptions to those in need. We also filled critical medications for patients even when our systems were not working. And we processed reimbursement claims after the fact because our number one priority was our patients. Meanwhile, our supply chain teams worked around the clock with our ocean freight and our aviation carriers in order to get essentials onto the island. We had more than 100 cargo containers arriving every couple of days, and more than half of those were just filled with water. Last but not least, we took care of our people as they worked to take care of our communities. We provided them gasoline, electricity and generators, water to our employees and their families, and we even continued to pay them when they couldn't show up to work because they needed to be at home with their families. In some cases, we had to pull back store teams who were overly eager to get up and running because we needed to make sure that our stores were safe for both our team members as well as our patients. I hope that I have the opportunity after tonight to talk with some of you and talk in more depth about what some of Walgreens does within our communities. I'm very proud of the teams that I work with, and I'm also very humbled by the chance to be able to serve in the best of times and in the worst of times. I'd like to close with a short video that we have of some of our recovery efforts this last fall.
So starting August 25th, we were hit with Hurricane Harvey in Texas. It was the first of 3 hurricanes to hit us within a 30-day period. During the height of the storm, we had hundreds of stores that we had to close due to torrential downpours, flooding, and just rough weather. We were able to mobilize our teams, and we were able to get these stores back up and running within a 24-hour period, the majority of the locations, to help serve our communities. Shortly after that, on September 6th, Hurricane Irma came across the U.S. Virgin Islands, Puerto Rico, and straight up through Florida. During the height of that period, we actually had more than 1,000 stores that were closed. During the aftermath, we mobilized additional teams. We provided resources and generators to those stores that didn't have power, and we were able to recover a majority of the stores, again, within a 12 to 24-hour period, with the exception of some stores that were remote in the Florida Keys that we could not access. During Hurricane Irma, the U.S. Virgin Islands St. Thomas store was completely devastated. We continue to work on rebuilding our resources there to get our stores up and operational. Unfortunately, just a couple weeks later, Hurricane Maria came through Puerto Rico and U.S. Virgin Islands again as a Category 4 hurricane, and through that process, it knocked out power to the entire area of Puerto Rico, including all telecommunications, all water supplies, and we were unable to communicate with our team members there. We were proactive as far as having generators on site, so we were able to bring up a good amount of our stores very quickly within the next day to help provide support to the communities. And we provided water and food and resources to our team members to help them recuperate. We additionally supplied resources to be able to get our stores operational, such as diesel fuel for our generators, water for the island, as well as construction materials. Remarkably, throughout all 3 of these massive hurricanes, we had no team member injuries. We worked tirelessly to locate every single team member so we could make sure that they were all protected and they were safe. So it's really remarkable to have all of our business units come together collectively to really try to solve our problems from end to end. So we were able to work with a lot of our partners, whether it be through government relations, through our vendor partnerships, through our pharmacy benefit managers, to solve the one problem, which was really trying to restore our communities and work together for that collective goal.
Loud voice, I can just talk. Oh, magic. So next will be followed by Joyce
Larkin, who is the Vice President for Corporate Community Relations with Cinti.
Good evening, and thank you so much for the opportunity. I'm going to date myself by saying that I started my career on Capitol Hill and had the honor of being a part of the very early days of the formation of the Congressional Black Caucus Health Braintrust, one of the things I learned from Congresswoman Christensen and Gary Puckrein at a very young age was that no is not an acceptable answer. So every day when I go to work, I try and think about what is the problem, and then what do we have with regard to solutions. Centene is a national Medicaid company. In fact, we're the largest in the country. We're in 29 states providing services to the Medicaid population, primarily looking at rural, medically underserved, medically needy communities, whether they're rural, whether they're urban, whether they're suburban. So you know and I know that it doesn't take a disaster for the day to be ruined, and for the community to be ruined, and for people to be without. But those disasters pull at every single community resource and then some. So I'm actually here, I very seldom appear on panels, but I'm here to appeal to be a part of the solution. How can we make sure we have the right definition of community resiliency? How can we do assessments that help health providers, first responders, and others to understand what we're actually dealing with in the community? And then how do we make sure we are not only prepared for disasters, but that we are constantly focused on what those challenges are unique to the community? We are operating in Florida, Louisiana, Iowa, North Carolina. If those states have anything in common, it's that disaster strike. Our RFPs and our business models that we have, our agreement with the governors, automatically have us being responsible for a lot of the patients that we care for. But if I know that there's a disabled patient who lives on the street, why should I only have to save and get medications and provide for support for that individual? That individual has neighbors, they have other family members, they have a community that they are part of. So we're pushing states to be a part of the solution at the table, helping to develop better models of care, not just for our patients, but for the community overall. How can we help? Bring us to the table at the early stages, because we know where the disabled populations are. We know the medications that they're on. We know when they have dialysis appointments. We understand their family members. So we can help map out, number one, where individuals are located. We can also set up pharmacies and other types of services, including behavioral health services, so that they can receive care. We can assist with the delivery of kits in advance. And we can also set up lines and phones so that they can notify family members in other parts of the country and in other parts of the world in terms of where they are and what their needs are. So we want to be at the table. We want to bring our expertise to the table, but then we want to learn with you what we don't know and provide solutions. So we have been involved in disaster response. In Florida, we were helping the prisons prepare to move their inmate populations to safety. We took our vision van and went to the shelters in Houston to deliver prescription glasses, to provide medications and prescriptions for individuals that need them. And that was great for here in the US. But then you turn your attention to Puerto Rico and the Virgin Islands, where those fragile hospital systems are shattered, where the Medicaid dollars and Medicare dollars don't exist, and where the communication and roads are impassable. So we were fortunate enough to be contacted by an organization called Healthcare Ready. They knew that we were a Medicaid provider, and they asked us for assistance as it relates to Puerto Rico and the Virgin Islands. What we did wasn't nearly enough. It barely touched the surface, and what it told us was we've got to be better prepared and at the table well in advance. But for Puerto Rico, we started airlift supplies. And it's very interesting because when you're working with your staff, they want to send toys. They want to send gifts. They want to send things that make people feel good. But when you look at what's actually needed, the water tablets, the diarrhea supplies, the diapers, the adult diapers, the kids' diapers, we started sending shipments that really mattered. And what we had to do was have the health workers meet the trucks or meet the plane in the main city get the supplies and put them on trucks and carry them as far as the trucks would go, put them on mules and put them on people's backs, and then reach those hard-hit areas of Puerto Rico that you saw on the news, where the tarp was ripped off, where the houses were basically left dangling on the side of a cliff, and people were without light and electricity, and some of them still are. So we did our supply relief, and we were assured that the supplies were getting there, and we kept constantly going back and saying, what more, what else? So we still have pallets of supplies that we will be constantly still shipping to Puerto Rico, but we also have organizations like the Association of Clinicians for the Underserved. They want to bring medical teams down to Puerto Rico to understand what else needs to be done. How do we make advancements so that solar power and the other kinds of things are there and available? And how can we help Puerto Rico be better prepared? But then we turn our attention to the Virgin Islands, which was even more challenging because at least in Puerto Rico, there were people that could call us from the cell phones and say, we're on our way to meet the plane, or that, you know, this is where you need to go, or this is the one clinic that's open. But in the Virgin Islands, just finding a phone that worked was a challenge for us. So we were able to reach a few of the organizations in the Virgin Islands to ship some supplies down to the Virgin Islands, but it's not enough. It's not nearly enough. So our lessons learned are that we understand our patient populations here in the US, in the rural communities, in the underserved communities, in those medically challenged communities, coming and bringing us to the table so that we can help prepare those populations should they have to move, should they have to leave, should we have to make adjustments to their care. But then how can we be globally concerned about these disasters? How can we be at the table finding out what works for Puerto Rico, for the Virgin Islands, and for other places? I was at my desk one day when we were dealing with getting the supplies to Puerto Rico, and I got a call from Healthcare Ready, and they asked if we had operations in Georgia. I said, sure we do. What do you have? And they explained to me, your dialysis patients who were evacuated from the Virgin Islands, evacuated from Puerto Rico, and placed in 7 hotels around the Atlanta area. Some of them had caregivers with them. Some of them had young children with them. Some had never visited the United States before, Georgia, and some, of course, didn't know they were leaving not to be able to return anytime soon. So there they are in the hotel rooms in Georgia, getting dialysis but no medical assessments, no prescription medications, no connection to their relatives. So we were able to make a phone call to our health plan in Georgia to dispense our community health center workers over to the hotels to have dialogue with those individuals, to take those individuals to a community health center, to begin running the prescriptions. And it's interesting because a pharmacist had told us what the prescription needs were, but when we sent our medical teams over, it makes a difference if a person hasn't had their prescriptions for 5 or 6 days. That's a different type of prescription. So unfortunately, the patients are still in Georgia. Some were looking for transitional housing. Some are notifying relatives and looking for other places to live. But there's a real large contingent of people who just want to go home. They just want to go home. And the interesting thing is one of our employees at Peach State Health Plan in Georgia went over to check on the patients, and there was her aunt that the family had been concerned about and hadn't heard from since the storm. She was one of those evacuees. So for us, disaster is personal. It's us. Our CEO says all the time, there but for the grace of God goes I. And when it comes to these disasters we're experiencing, there but for the grace of God goes any of us. And so we're here to be committed, concerned, and to roll up our sleeves and work more closely, not only with the Health Braintrust, but with all the partners, all the government entities to see how we can, be a part of a new strategy around resiliency and thriving communities.
And President C. Reynold Verret, who's the president of Xavier University in New Orleans, will close out our panel before I ask intriguing questions.
Intriguing questions. Well, I come from Xavier University in Louisiana, and as you know, uppermost in our mind is what happened a decade and some years ago. Katrina came in. And we are still focused on knowing that we are below sea level, that one day, somehow, the water will come in. And that preparing for that requires not thinking of exactly how we can physically keep the ocean from coming in, but as the Dutch would say, of how to live with water. But living with water when water comes in is being prepared to say what happens after the water rolls out, how do we recover. Many lessons were learned from Katrina. One was about the coherence of our society and community. For example, in emergency planning, one of the, I would say, fundamentals was what you do with the immobile population. And in Katrina, we forgot the immobile population. The buses were flooded, and we did not think of that the majority of residents of New Orleans did not drive. But that also has a sense of doing that the city was fragmented, that I did not think of those people as my people. It's a larger problem. I am an educator and we are an educational institution. Part of our thinking as we have looked at the rebuilding of education in Louisiana, completely destroyed. The entire K-12 system had to be rebuilt. It's predominantly charter-based right now. But in thinking of what we do, despite the fact that we at Xavier, we are able to produce the largest numbers of physicians, African-American physicians, who go on to complete medical school. The largest numbers of students who go on to become PhDs in the sciences. And not just in the sciences, we have 4 federal judges who are alumni on the bench right now. For a school our size, we have no business having that. So we do well. But in that doing well, I can tell you there is a secret sauce to it, and the only element, without divulging a trade secret, expectations of students. The way we have very high expectations of them, but also every student comes with us at some point, has some lacunae, some deficiency, some gap in his or her preparation. Because one of the things that we do know at Xavier is that students, especially African American students, underrepresented students, do not often get the education that they deserve. And I say they deserve, not through faults of their own, because no child chooses his or her school, no child chooses his parents or how he or she is seen in the society. But we do well with those students who come to us. But let's worry about those who never come to my door, who never come to any college's door. That is the majority of the talent pool in the United States. And from my perspective and perspective of my colleagues throughout many higher ed institutions, we know clearly that that talent that is wasted was there but has not been cultivated. We also know that education, I would say, is a sine qua non for all the other things we want to do, whether it's health, public safety, whether it's economic development, that if we don't have an educated population, it's hard, very hard, if not impossible, to get some other things done, that we need done. And at the same time, we do not cultivate our children. And I would say my definition of resilience, of a resilient society, of what I call a well community, dealing with community indicators, coalitions, and things like that, is what is the key indicator? We struggle with key indicators. And I would say key indicators are flourishing children, children with hope. That is a resilient society. If you have that element there, the rest is already there. We do not have flourishing children because, understand, I would say that in the United States, the Constitution is framed in such a way that we have not given all the benefits of the Constitution to children. Understand, I cannot exclude an elderly person from renting in my apartment. But I can exclude a child. and allow pets. So that's never been tested in the Constitution. I'm not a lawyer, I'll leave that to the lawyers. But understand that in our society, if you do not have resilient, ornery advocates, which means a parent, to speak on your behalf as a child, you're doomed. We also have an evolution in the last 30 or 40 years because of fragmentation of our communities, that if a mother, a single mother has a child, when my grandmother had a child, back many years ago, there was always a community around her who would embrace her and teach her how to become a mother. And I understand that when I became a father, I knew nothing about being a father. But there were others who told me, Reynold, you need to do this. Our communities are fragmented. We also need to think about how do we prepare parents, especially parents who are by themselves, to take on the advocacy role for their child. That doesn't mean to be the expert, because when a parent comes to a physician and speaks for his or her child, they are speaking for that child and advocating for that child. In our educational system, the experts, being the teachers and the principals, speak for the child, and the parent is infantilized. How do I prepare my parents to speak for that child and say, my child is not to be left in that grade, he needs to be promoted. Or my child's not, is that grade you gave him an A, but he can't write. Or she can't write. And the he is an important part of it as well. So building education is building resilience. A society that is able to respond when the crisis comes, not if the crisis comes. That is the crucial part, but also to do this and build our communities, we need the parents, and we need to give them what they need. Understand one data point, for example, that to me stands out is that African American families are the highest, African American parents are the highest to use corporal punishment. A legacy of slavery, because that's how we treated young slaves. That education that comes from older people with grayer hair to tell you how to raise a child when you are by yourself doesn't come. So we need to work hard and think within our public health, and I'm broadening public health from a very large term for well-being in a very broad term, is that how do we, in my obstetric clinics, my wards, as I'm leaving, sending a mother home, and I've given her lactation classes, how do I prepare her to be the person who stands for that child? Because only children will define resilient communities. Ready for that. I would also add the other piece that's important in our community is political work. We have power, but we don't use it. A friend once spoke of Ferguson and pulled me back from the Ferguson discussion after Michael Brown was killed and said, you know, everybody's guilty. Maybe that he used the old Abraham Herschel line that we may not all be guilty, but we're all responsible. He said, if we had used our voting power, there would have been a different city council, a different police force, and Michael Brown might be alive. So to take on the political power we need in order to make sure that our communities have what they need is an important motion. It's more than a medical problem, but it is a medical problem. So I would leave you with education, with the preparation of parents so that we embrace our parents and give them the wherewithal to be the honorary parents to speak for a daughter or a son. And political power. That is the element, because the storm will come. The levee will break. But we have to be ready when the levee breaks and when the water leaves. Thank you.
So I have one question for each speaker. We'll go in the same order as before, and then I'll open it up to you all in the audience. So Representative Plaskett, my question for you is, so as the hurricanes hit, I would argue that most people in this room saw either a blip on 60 Minutes or a blip on the TV screen, a couple of pictures, but you were there, and those are the people that you represent. What is one thing that you wish that mainland Americans knew about the resilience and the response in the U.S. Virgin Islands, specifically Hurricanes Irma, which hit St. Thomas, and Hurricane Maria then that hit St. Croix?
I think the thing that people really did not get a full picture of, and those of us that were there, not just during the storm, but more importantly in the aftermath, was the strength and the sense of community that does exist in the Virgin Islands. St. John, which is a much smaller island, is really isolated. There aren't planes that can come there. It's usually just a ferry that goes between St. Thomas and St. John. And so for several weeks, you had a great difficulty getting to that island. And the people of St. John organized themselves. They didn't wait for FEMA and others, the local government. They had clipboards out as community members, I saw posted on Facebook, because although people couldn't use cell phone, in some places you could get Wi-Fi. And so they were using Facebook and other social media to communicate. And they literally had brown paper bags and were writing the names of everyone that they could find and posting it on Facebook so that loved ones would know who was alive and who was accounted for on that island. And then organizing boats to go back and forth between the islands. On St. Croix, the island that I live on, in the immediate aftermath of Irma and before Maria, people on St. Croix, nonprofits, communities began making lists of homes on St. Croix where children on St. Thomas could come and live. Finding out where children had family on St. Croix to get boats over to bring them so that they could continue at school before St. Croix was destroyed. I remember, much to the chagrin of my husband and maybe my staff, I needed to get to St. John and couldn't find a way over there. And so I went to the waterfront where the fishermen are on St. Croix and just jumped on someone's speedboat. Because at any given time, there were yachts, there were speedboats filled with water, diapers, anything that they could, batteries, and they were making this journey across to get supplies back and forth. So the ability of community to want to save themselves is something that I think was lost in the media. That there is a sense that we were asking and needing the support of the federal government. And what I think people didn't understand is that, one, we wanted our fair share, like everyone else, but that we had the means, once given the resources, to be able to care for our own community. And the one thing that I would say about the lesson that I learned was the need to have a much better coordinated and logistics between those community leaders and individuals and volunteers in the community with local government and federal government and the private sector. That for many weeks there was kind of just this madness about people just wanting to do everything and there not being coordinated support in how to get that done. And that, I think, speaks to, one, the real heartfelt humanity that people have to want to help others, and it being thwarted by the lack of systems in place to do that. And I think that that's something that once we figure out how to do that, will make us better when this happens again. Because we all know that at some point this is going to happen again.
Thank you for sharing that with us. Dr. Sharfstein, can you speak to what you see as next on the horizon in the space of public health and resilience? And then kind of as a follow-up to that, what is academia doing? What are we doing to prepare communities or to prepare people who are leaders of organizations to respond to a public health crisis?
Thank you. I think it's really important to realize that the kind of skills that you're talking about are valuable for some of the challenges that don't require a hurricane to hit. There are a lot of parts of the country, there are parts of Baltimore, there are parts of many places in the United States, urban and rural, where there are incredible crises going on, and some of the resilient skills that come out can be nurtured and used for challenges like the opioid epidemic and other major challenges. And in fact, it's very hard to be at a constant level of preparedness for a hurricane if you're not practicing the kinds of leadership skills, like to your question, how do you get local government and community organizations and working with each other? My answer to that would be you have to do that in between, around the kinds of challenges that people have. Oftentimes there are a lot of programs that just sit there and do things and don't engage that much. Those are missed opportunities. A great annual example of that would be the flu season and the opportunity that exists to really get out there and get people vaccinated, for example, and to do a lot of different collaborations. So I think that there are opportunities to build resilience and to use resilience for the challenges that really affect people. Now, how to take advantage of them, I do think that academia plays an important role, or at least should play an important role. One of the opportunities I wanted to make people aware of relates to an initiative that has started at the School of Public Health that I work in called the American Health Initiative. We are focused on 5 major challenges facing health in the United States, including environmental threats like hurricanes and climate change, adolescent risks, obesity in the food system, addiction and overdose, and violence. Those are the 5 areas. And as part of that initiative, we have 60 full scholarships that we give a year to people who work on the front lines of those problems. It's a full scholarship plus $10,000. And all we ask is that they continue to work at least for a year with their organization. It can be a health department, it could be a health system, it could also be a community anti-violence organization, it could be a court system, multiple planning organization, community development organization. If anybody has any interest or knows someone who wouldn't necessarily be thinking about public health, we want to have a relationship with the organization. We want to train people and strengthen the organization with people who understand how to, can understand how to use data in an epidemiological way, as well as, engage with all kinds of different classes that may be helpful to communities to build capacity around these issues. So, basically my answer is you don't have to wait for the next hurricane. You can do many, many different things, and you can partner now. I hope that anybody is interested. It's americanhealth.jhu.edu. You can read about all the different opportunities, or email me, josh.s@jhu.edu, or join my mother and 2 of her closest friends and follow me on Twitter. At Dr. Josh S.
Thank you, Dr. Sharfstein. So I would challenge at least one person in the audience. If no one does, it'll be me. But please stop Dr. Sharfstein before he leaves today to find out more information about this program. I think one of the reasons that I didn't get a master's in public health during med school is that I'd have to pay 2 tuitions at the same time. And when I talk about mentoring young people, one of the biggest things in undergraduate school and in graduate school is how am I going to pay for this? And so.
Let me just say this program can be part-time from wherever people are anywhere in the country.
I'm jealous of whoever is about to approach you. So I will move on, and I will ask Amanda, and it's interesting that we teed up this way. Dr. Sharfstein spoke to how he didn't think about the role of pharmacies in responding to a challenge or a healthcare or a health challenge. And so I wanted to ask you, what is the immediate and the long-term role of retail pharmacies in responding to disaster?
That's a great question. I think our role is multifaceted, and so when I think about retail pharmacies, I think about Walgreens, I really segment it out into 3 different pieces. The first is the retail piece, the front end piece, where you end up getting your sundries and your groceries. And the second piece being your prescriptions in your pharmacy. And third being your healthcare services. And so when you think about those 3 components, and you talk about what's our role in being able to provide those 3 components, either short-term or long-term, I think it comes down to what's your business continuity plan look like up front? And both of you have already touched on this a bit. And I think it's so important that we really take the opportunity on what we call blue sky days and really plan out, what are the different components and the critical factors that are going to make us successful to be able to service our patients and our customers and provide that care that they need. So I think that's number one. We need to make sure that we put the appropriate resources towards the planning efforts. The second piece, I would say, is that we need to make sure we're leveraging our relationships with local and state agencies. I think that we need to make sure that we are transparent and open about where we have challenges. And that creates a bit of vulnerability, especially as a retail pharmacy, right? To kind of peel back the layers and say, this is where we either didn't do so well, or this is where we had a challenge, and this is where we did really great. And be able to share those experiences and talk with other companies and agencies to figure out how can we share some of our lessons learned and some of the highs of what we went through, and where can we get additional input to continue to build our program so that others ultimately can benefit from it.
Thank you. To my left. Joyce, can you speak to what is the role of the payer, of the major insurers, with regard to resilience? And it's amazing that Centene has been at the table. So when we think of folks who might not have been at the table, or if we're from states that Centene does not cover lives in, how do we engage in the other payers or the insurers in our state and get them involved in ways that Centene has?
I think for Centene, we really don't see ourselves as insurers. We see ourselves as part of the community, because after all, our operations are there, our employees work there, we attend church there, so it's our community as well. So we take it upon ourselves to be engaged in the community. In fact, we're headquartered in St. Louis, but each of our operations have their own CEO. They all have their own employees, and they have decision authority. We're there to support them. And so for the last couple of years, we're headquartered in St. Louis, so we are part of the Ferguson experience and the rebuilding that's going on there. We've been responding to disasters, and we are now helping out the students in Florida who are impacted by the Parkland shooting with our mental health counseling, with our crisis lines, and by joining the counselors and going into the school and even setting up crisis lines for counselors. But let's go back again to what it is we would like for everyone to be a part of. If we understand that we're part of the community, then we can identify other corporate partners, whether it's Wells Fargo, whether it's Shell Oil. In some states, we're one of the largest employers in the state, so we can appeal to these other corporate entities and partners to join us and help us to try to rebuild and address what the community needs are. It's been very interesting, too. We do some work with youth around the country, and the first responders, those police officers, they have been coming so they can better understand what the needs are for those youth. How do they dialogue with the youth? How do they interface with the parents? Another example of how we can begin to bridge gaps, make our community stronger, and involve everyone in being a part of the shared community example. I think that a lot of the experts who are out there in the community leaders, the pastors, the teachers, I do agree. I think they've been overlooked as being part of the solution. So as we come into communities and as we start to build the solutions, we really have to engage everyone in that community to be a part of the solution.
Thank you. And now, Dr. Verret, I am not a Xavier alum, but I'm a proud alumna of a historically black college or university, Spelman College. It's the best. So I, humble brag, but so as an alumna, and when I think about the fact that after Katrina, so many of our HBCUs kind of opened doors and had students who came temporarily or permanently to continue their studies, my question for you is there a work group among historically black colleges and universities that is looking at resilience and response? And if not, should there be? And then my last part is, how are we engaging with students around conversations with resilience, and is that something that we should be doing as HBCUs?
I agree with you that it is something that we should be doing at HBCUs, but it is not. There is not a consortial discussion among all the HBCUs. I know at Xavier and also at other HBCUs, especially those on the coast and also in Florida, those discussions are occurring as to how to be resilient. Sustainability and the environmental questions are front and center in their minds. What we do need is a larger conversation about what we need in our communities to be well, and how we put that and how we put those elements together. For example, one of the questions about that HBCUs have been having, not just only the private ones but also the public ones, are their influence on local education, of how they should influence K through 12 in their region, and also influence educating the community in the sense of not just educating young people but also the adults to what they need to have other knowledge about medical issues as well, but also other issues that should inform the adults in the communities as well. That's a larger element that HBCUs throughout, especially throughout the South, but also throughout wherever HBCUs can be found, even in the North, can play within what I call their catchment areas. So that there's a large, but also the intellectual resources within the HBCUs for analysis and for looking critically how we do and what we do, whether we do it well or not, is there within many HBCUs. And there have been some consortia about that. For example, Bob Bullard, when he was in Atlanta, ran the HBCU Consortium on environmental racism. That intellectual base has fed the discussion not only in HBCUs but throughout the nation. So there is an important resource there among HBCUs. The question of African males has been a question that has been very important for HBCUs. That HBCUs are aware that, for example, present in many HBCUs that are mixed sex, the ratios are 70-30, 70, and the question of African American males is not just within the black community, but also among whites as well, because the college-going population is 60-40 nationally as well. So the crisis that is going on there of asking difficult questions about how do we repair that, because it ties to many other societal issues that we are facing as well.
Thank you very much. So now we're going to open it up to the microphones. As you can see in the audience, we have very long lines. If you hurry now, you might be able to ask your question. We've got a runner. Oh, great.
Oh, wow.
Good evening, everyone. My name is Andrew Morrison. I'm the Chief Operating Officer for Mentoring in Medicine. Over the past 10 years, we've helped over 500 low-income students, B- students, become physicians. My question is to Representative Plaskett. I've done work in the Virgin Islands, and thank you so much for that presentation. This week, the Economic Development Agency just released a grant, some $580 million. And it focuses on resiliency. I want to encourage everyone to take a look at it and how you can begin to use those funds to be able to support areas that have been impacted by the hurricane. So let's work with me on this thought exercise. So let's imagine Representative Plaskett just received $10 million, okay, to build resiliency in the Virgin Islands. And now I'd like you to turn to all of your fellow panelists, and you have to give each of them, say, $2 million, okay? And so you have $2 million to each person up here. Even our moderator gets $2 million.
Thanks.
And how would you distribute the money, and kind of what resources or what kind of support they could give you?
Based on the positions that they have now?
Yes.
Okay. Well, can I desegregate it differently than $2 million each? I think that the bulk of the money would be between the good doctor sitting next to me and the other doctor to the end, because they're in education areas. And I think that the primary issue in terms of resilience you'll find in a lot of communities is the disparity in socioeconomic areas. And that socioeconomic areas based upon education. And so if I could create resiliency in our educational systems and support to our students, I think that that would take us a long way in terms of our resilience overall. So having Johns Hopkins be a place where studies were done, or resilience in public health for our young people that required them to come back and be involved in the public health sector in the Virgin Islands, I think is a critical need that we have. Having the scholarships for our young people to be at Xavier or places like that, and requiring them to come back to help reverse our brain drain. Let me explain, just in terms of education. After the hurricanes, it was so much easier for the private schools to reopen, who were motivated by the need to keep those students in place. They were open within 2 weeks, not even a week in most instances, whereas the public school students waited about almost a month. And the private schools were full-time, and again, the public schools are still on 4-hour shifts. That's gonna have tremendous impact on our economy 10 years from now, 20 years from now. So for Walgreen, I would give $2 million not only to their, for them to be able to support the issues of keeping their stores back open, but to providing healthcare in communities so that our elderly do not have to go to the Walgreens to be able to get the support and the medicines that they need during that time period. To give Joyce Larkin, and I have to let you guys know, Joyce and I go way back to when I was a staffer on the Hill, and she was a staffer as well, and then we both had the good fortune of working for a different healthcare company. But to allow them to be in the community, to have healthcare workers that can be mobilized immediately after, I think that's how I would spend the money.
Great, thanks.
Okay. But I need more than 10 million.
Question over here.
Okay. I wear many hats at the summit, but right now for this question, my name is Dr. Christopher Irvin with the Innovations Learning Lab at Morehouse School of Medicine. And I do appreciate the wonderful discussion that this panel has had regarding resiliency, particularly based on the robust definition. I approach this question from a different perspective. I've appreciated all the examples of resiliency from the top, but based on the definition of resiliency being very community-driven, this question is coming from the standpoint from the community side, particularly when you looked at many of our audience members are not healthcare providers, healthcare professionals, academians, they're community people. And there was not enough spoken about what the community can be done, particularly what can you guys do to enhance, embrace the community to be resilient. And I've approached this question from the standpoint of something that many other nations, areas of the world already do, is utilizing community health workers to not only build resiliency, but maintain resiliency both in times of normalcy and lack of health care and in times of disaster. Right now, I'm actually working on a program where we're training high school students to be community health workers. We're working at the state to formalize the work of community health workers. And one of the reasons why it's an issue is because such as providers do not pay community health workers. And so if we're talking about resiliency, particularly in times of disaster, what can you guys do to make sure you strengthen those people in the community to be resilient at a level that not only sustains themselves, but all their members? So for example, in the USVI, when you're trying, and Walgreens trying to deliver medicines and relying on your own workers to use trucks, planes, trains, automobiles, and mules, when you could have people there trained as community health workers who could emit those vehicles and done the distribution and education for you.
So since I'm the moderator, I'll start. So I think that a lot of the work in resilience that has been successful has built upon this age-old model of community health workers. Whether they're called promotoras in some communities, whether you call them community health workers. Working in public health, one of the biggest challenges that we've had in Pennsylvania is around payment. And so I think really it incorporates the message that it kind of, a little bit of everyone's message, but you've got to vote for the people who are going to support this as an initiative, who are going to get it through our legislatures, who are going to fight for a living wage in some states. So there are, I think, a lot of times people at the top who have a great vision and tell their workers we really want this to really happen, but their understanding at the top of what's going on the ground is not always the same thing. And so it's really important for when someone is saying, oh, we've got this great model and people are being paid, if the community health workers aren't being paid, we've got to get that message back to our capitals, we've got to get that message back to Washington to say we need to make sure that there's a fair and living wage for these workers and that they're really getting what kind of the lip service that is being had kind of in the larger discussion.
If I may take a piece of that as well. And I'm speaking maybe to Walgreens, to CVS, to the others as well, but also the state of Pennsylvania where I was dean at one time. One of the questions, for example, I'll take the example of pharmacy. Some 30 years ago, we began the PharmD, as opposed to bachelors of pharmacy. We educated PharmDs to do much more clinically than the previous generation of pharmacists. They can make medical assessments, they can manage patients, but there's never been a reimbursement model to say exactly how do I use these workers to actually do that. While if I leave the country and I go anywhere in most parts of the world, for many places, the first place of contact and interaction with the medical system is at the pharmacy. And I know, having worked on some grants, which I was for the New York Health Hospital Corporation, where we were reviewing them, one of the models was also how to use local pharmacies to manage HIV patients in compliance with medicine locally in my neighborhood at the corner rather than 15 minutes down the street. We have other dysfunctions in our healthcare system where we don't fully utilize what we have, given the fact that we have more people getting older like me who will need you. So that's one aspect of how we use communities. But also in communities, for example, what we do, for example, in Georgia and also in Philadelphia, my local fire station has always been one place that has done much more in monitoring blood pressure. And they are not physicians. They'll tell you blood pressure, come in, and then they'll refer you. That sort of broader use of the system rather than everything with a specialist is something that we probably need to think about. But it's not just in health, it's in many other things that we need to do because, as I mentioned before, the notion of resilient communities is much more than just the technical part. It's societal, it's also part of the larger community building that we have to do.
And for Centene, we're a national Medicaid company, but we've started calling ourselves a state solutions company because when the federal government can't move, governors can. So it's very interesting, as we responded to the incident in Ferguson, our response was to put a new claim shop right in Ferguson and to have 98% of those jobs go to Ferguson zip codes. But because we were handling medical records, we had to work with the state to be able to allow individuals that might have a traffic ticket on their record to be able to allow them to have that removed from their record so we could hire them. But the state did that. We also had to work with the community college because some of the jobs required different types of certifications. So the community college was able to build a program so that we could build the workforce that we needed right there in Ferguson. The reimbursement models and what the government and others are willing to pay for, it's a challenge. But the governors understand that. So we've been able to talk about how do we make sure the partners that we work with receive reimbursement. Interesting enough, we have some HBCUs that are actually coming inside the prison walls and helping us to provide care for the prison population. They're getting paid for it. We've been working with the National Urban League, and they have been doing community reentry for individuals that were incarcerated. They're getting paid for it. So there are innovative payment models. There are strategies out there. How do we make sure you're aware of how to do that? And how do we take some of the states that are willing to put forth these models and then have them pressure other states to give it a try?
If I could just say one quick thing, which is, I thought there were two parts of the question. One was community health workers, and the other was supporting what communities see as major priorities. One of the most interesting projects I worked on when I was with the state health department here in Maryland was a project that was led by the Lieutenant Governor and now Congressman Anthony Brown, called Health Enterprise Zones. And that project had a couple components. One was that we gave very specific data to different communities around Maryland, and the second is the state made resources available and the community had to create a coalition and come forward with what they wanted to do, we encouraged them all to use community health workers, but they came forward with very different projects in different parts of the state. On the Eastern Shore, it was about behavioral health. In Southern Maryland, it was about transportation, access to care. In West Baltimore, it was actually about, they created a training program for community health workers and focused a lot on cardiovascular disease. And I thought that what was really interesting is I got to go to all the different planning meetings and just see just an incredible level of interest and activity. And so I think, it's important to go in both directions, but if you can, and when I was in the city, we did the first reports about life expectancy by neighborhood that any city had done. And we used those reports and a lot of health information down at the neighborhood level and tried to give support to neighborhood activities. I think it's a good model to give people data and then make resources available and really provide technical assistance, but let communities come up with different ideas and try to support them as in addition to other more traditional ways of support.
Can I just say that when the hurricane hit St. Croix with Maria, my office in Frederickstead did have a generator, but because of cellular issues, we really couldn't communicate well. In the town of Christiansted on the other side of the island, they had buried a lot of those lines underground, and there was a nonprofit community center there where I and many of my staff sat for about 6 weeks. And that community center knew where all the resources were because they're there on the ground on a daily basis. And when the federal government or other agencies were trying to figure out how to do something, I just looked up to the executive director and be like, who's the person on the ground who knows how to get this done? And they knew immediately who the right people were, because the people that are at the grassroots level and the ones that are doing the work on a daily basis are the ones that really should be the most tapped into what the real needs and resources are for an area.
So we have one more question over here, and then we'll get ready to close out.
So my name is Kevin Wang. I'm a family medicine faculty at a residency program in Seattle, Washington. I'm a little embarrassed because I feel as if my question's very narrow focused, but my question is for Amanda Quinton. So first of all, I think it's really fantastic what Walgreens has done to support areas of disaster, and I wish we could have more retail pharmacies really just showing and paving the road for that. Okay. But in the spirit of improving communities' health and everything, especially since communities of color and vulnerable populations had difficulty with access to certain insurances, I've noticed that some retail pharmacies have opted to not contract with certain Medicaids due to low reimbursement rates. So do you know if there's any kind of movement within retail pharmacies to help improve access for medications for patients with certain insurances? Sorry.
No, it's
on the spot.
I know it's very narrow focus, but you were here. It's a perfect opportunity to ask.
It's a great question, not one that I have the professional experience to be able to answer. So I really will have to table it and bring an answer back, as my focus is more on rebuilding the infrastructure components in order to deliver that. So I will circle back around with you. How's that?
That'd be perfect.
Okay.
Thank you.
So I'd like to ask each of our panelists to spend 1 minute, which you all have done great with times one of those minutes, to offer some concluding remarks to our audience and maybe a charge of what we can take away and what each of us can do to build resilience kind of where we live and where we work. We'll start with Dr. Verret.
Less than 1 minute. I think what we are doing in our partnerships with other organizations within the community, whether it is the K-12 schools, whether it is other hospitals like Ochsner, the LSU system as well, with the local pharmacies, but also in community, because there are many small enterprises that have grown, for example, Propeller accelerating down the street from us, that are building economy and enterprises in our community. We are partnering with them in many ways. Those partnerships where our students themselves are serving in those community, in those organizations, but also learning as well, I think is extending the capacity of the community. I think the elasticity of the community is being able to have those relationships so that, as the Congresswoman, Congresswoman has mentioned, allows us to actually respond in much broader ways because people know where things are. It reminds me of when I was a graduate student that the students themselves were the people who knew where everything was, not the professors. It's important that people actually have those relationships, that we extend our networks and not stay within our own boxes or silos.
Our communities are urban, they're rural, they're suburban, and we share the same goals. We also share the same challenges. So to be able to look at ourselves as part of that community, to be able to be more engaged with as being part of the solution, and to be able to engage the community as a vested stakeholder in the outcome is ideal. It's where we want to go. But we also have to be very, very, very diligent with regard to technology and how are we going to use technology to better improve our communication, our infrastructure, the time and the data that we need to share, and how can we help states understand the importance of investing in technology. And then I'm also very, very, very concerned about tomorrow's workforce. I know that I'm in healthcare, and we've got to be able to make sure individuals understand not only the role of technology, but how will the future workforce actually use that technology to be able to make faster, better decisions around some of the health challenges and rising health concerns that we have. So again, being one community and also being able to take lessons learned from any community that has suffered disaster and being able to figure out, is this something that we need to raise to the national level, and how can we, learn? How can we apply lessons learned even in the midst of a disaster? Because I think it's invaluable.
Yeah, so on the community front, right, we've all said it and talked about it, and Joyce, you said it again, right? It's so important to be able to recognize, right, that we're all part of the community. It's you and I, and it's my parents, and it's kids, and it's my friends, and it's my coworkers, right? And so we're all really working towards the same thing. And I think as we talk about what some of those takeaways are, what some of those challenges are that affect all of us within the community, I think it really comes down to making sure that we have a plan and that we're investing within that plan. And I talked a little bit earlier about that vulnerable moment of being able to say, here's where we think we have some gaps, and being able to really partner with, whether it's your neighbors or whether it's agencies. And one of the things that we did during our recovery efforts was I picked up the phone to one of my colleagues at Walmart, which is typically not what happens. Walmart, and Walgreens don't typically get together to talk about how can we leverage each other's resources in order to rebuild a community. And to me, it really comes down to, we all need to put our egos aside because we're just trying to rebuild the community. It's about you and I and our friends and our families and our coworkers. So I think that continuing to partner and have those relationships flourish and have that networking to be able to build those plans and put the infrastructure in place and have the data and all those things that we've talked about tonight, I think is really the, what I want to champion here as we move forward.
Dr. Sharfstein?
Right, because when you think about it, we're all just pharmacies that start with WAL. I'm just saying. I don't know if that ever came up. So I would say that there are crises all around us. There are opportunities to build resilience all around us. You mentioned a bunch of them. Even just in the course of the conversation, the condition of schools, the hypertension, the nation's leading silent killer. There are all these challenges around us, and I think the opportunity is to take one of them and build resilience around it and make a difference and develop systems that can be used for other kinds of disasters too.
I was thinking of a word that the millennials use now is intersectionality, right? And I think that works at two levels and is kind of a key for us here. One is the intersectionality at the community level, at the lower level, where we are able to integrate a Walgreens and a Centene with nonprofits and health clinics that are in communities to do the work that's necessary there, along with the young people and the students that are in those communities. But also using intersectionality in the skill sets and the businesses that make up something like the National Minority Quality Forum, right? And using that in the experience you have from working at the lower levels to be able to effectuate change and be supportive of legislation and federal mandates and policies at state levels and at federal levels that support those communities and the work that's being done on the ground. So I think that's really the long-term need for resilience, is to make sure that we have the systems at the lower level and really taking the lessons learned and the needs that we get out of that to be able to effectively work together to make those policy changes at the state and the federal level as well.
So on behalf of the National Minority Quality Forum, I really would like to thank our panelists tonight, if we could give them a round of applause. And I would like to thank you all in advance for the challenge that I'm going to issue now, which is I'm asking each person in this room to talk about resilience with two people who are not in this room. So it's very easy to walk out and talk with a colleague, that was a great panel. But I'm asking each person in here to talk to two people, one of which could be your parent. But each person talk to two people about resilience and about what you can do where you live, where you work, and where you play. We talk about the social determinants of health. We each need to do something because we can't put it on anyone else, and it's up to us. So thank you all for sticking with us through this evening. We look forward to another exhilarating day tomorrow, and get some good rest. Thanks.